Hello, this is your brain on drugs, and this is the punk rock psychiatrist. And that was Screeching Weasel's Speed of Mutation. So, pick that one once again. Had last time we did Speedball, this time Speed of Mutation. So I thought, having speed in there when we're talking about stimulants and their relation to amphetamines makes sense. So today we're going to finish off the stimulants. We've got tons of methylphenidate products, and I'm going to talk about the remaining ones that we haven't talked about yet. We're going in chronological order, so these are the newest ones. And then I'm going to talk about modafinil and armodafinil as well, which are stimulants that are not approved for ADHD, but sometimes might be used, and we'll talk about that as well. So let's go ahead and get started. And, I learned something today. Our first product up, Adhansia XR. Now, this is a product that I've never seen and I've never used. And you know what? I never will because it's gone. And apparently it was gone in 2022 and I had no idea. It only came out in 2019, so this product only lasted like 3 years. It's not clear to me why they abandoned this product. My guess is that it wasn't selling. I mean, as you can tell, we have so many methylphenidate products and they are so similar to each other. Did Adhansia really have enough to stand out to make it a product that was going to make any money? Perhaps not. Um, Maybe I'll kill some of these drugs on this podcast because I think a lot of these don't really have much benefit over other ones, but yet they don't go away. What happened to you at Hansia? You actually bit the dust 3 years into production. And this is a drug that, doesn't necessarily, it's not like super, super similar to other ones. It does have a couple of things that um, put it apart from other medications. And, it's possible that it could come back. So I thought, let's go ahead and talk about it anyway. You may remember it, you may have never heard of it, but I mean, it was out pretty recently. There are some things that set it apart. This is another methylphenidate ER product, so it's a long acting methylphenidate. It was dosed 20 to 100 milligrams, with 25 milligrams of this medication being equivalent to 20 milligrams of methylphenidate or Ritalin. But that max dose of 100 actually is equivalent to 80 milligrams of methylphenidate. So I'd say one thing that was different was this is the first methylphenidate product that actually had an FDA approval over a dose of 60. Not that you could not have done that had you wanted to go off label, but here is one difference. If you wanted to go above 60 and you wanted to be within prescribing guidelines, this medication actually gave you that ability. It was a capsule, same onset of action, 20 to 60 minutes, time to peak 1 to 4 hours for its initial peak, 8 to 14 for a later peak. That's for kids. For adults, it was 1 to 2.5 hours for adults and 8.5 to 16 hours for adults. Here's another thing that makes this drug a little different. You may see that last peak, 8 to 14, 8.5 to 16. This is one of the longer acting products that was out there. Duration 10 to 16 hours. That's kind of a big range, but it was known to perhaps last a bit longer. So there's another potential benefit this medication had. It was you could split it. You can't split a lot of these products. Um, it's a capsule, so you kind of have to be careful. It's got the beads in there, but like a lot of these methylphenidate products are not splittable, and it was. So let's go ahead and have a look back and see who was splittable that was not like a chewable or a liquid or something like that. So Journey splittable, but that's a very particular one where it was like had that significant delayed release, where you took it at night and it worked in the morning. Can't really substitute that for other stuff. We've got the ODT product, of course, is splittable. We have Aptensio is splittable. Quilichu, of course. Quilivant, of course. Daytrana is not. Can't cut patches. Those are the newer, more expensive products, and Adhansia kind of falls into that. So a lot of those are splittable. The older products, less so, like Concerta, you can't split. Ritalin LA, you can. SR doesn't, exist out there anymore. And so, yeah, the one that I reach for the most often, Concerta, within the long acting methylphenidate products, is one of the ones you can't split. So that's kind of a disadvantage there. But these newer ones are mostly splittable. Adhansia did fall into that category. Um, Use of age 6 and up, that's the same for pretty much all of these. And one thing that did set it apart was it had a very interesting technology called MLR, and that's like patented MLR, multi-layer release technology. It's actually one bead. So it's got 20% IR drug in a layer and 80% CR controlled release in a layer. And so you basically had one bead. And the way this thing is, you've got the outside coating of the bead is the immediate release 20% drug that it has in it. Then you have underneath that layer, you had a delayed release polymer coating. Under that layer, you then had the controlled release polymer coating. And then under that, you had an extended release methylphenidate layer of 80%. So kind of interesting. You had to eat through two layers, a delayed release layer and a controlled release layer, before you get to your extended release layer. And then there was a sugar core. So it was one, instead of having two different beads, like some IR beads and some extended release beads, it's one bead that has both the immediate release and the extended release. Concerta, a little bit like that, but it works different with that push compartment through the laser hole thing. Um, so that was kind of a cool thing it had going on. And I'd say it made a bit smoother um, curve. You do have a bit of a dip in between when that we get to that extended release part of it. The IR is kind of worn off by the time that happened. Um, and this, we can't even make this generically until 2038. And so, even if you wanted to say, hey, let's make Adhansia, you can't. Okay, so one reason you can't is because its patent's not expired for like another 13 years. This is probably the latest product out there. You'd almost think that the company would be like, wow, we have a patent on this for so long. We should take advantage of that. Like a lot of these other companies' patents are going to expire and ours is still going. We can still make money on it. And then they also have, kind of like Concerta, they have this multi-layer release technology that they've created, this, right? Because like with the generic Concerta, they can't make the Oros. They have to make it differently. And that's one reason why we talked about before that like the branded Concerta is actually superior to the generics, and why the Relexi, the brand, which is a branded, kind of a branded generic in a way, it has its own technology that's not Oros but is similar. And remember, it only has the one push uh, layer in the middle, container in the middle, versus Concerta, which has the two um, the push layers, where the osmosis kind of pushes the drug out through the hole in two blasts versus one with Relexi. So you can't really make a generic of Adhansia because you can't use this multi-layer release technology. You'd have to make something kind of designed like it, but not exactly the same. And so good luck getting a generic, because it's going to be 13 years. By then, we'll probably have new products that we won't even care that Adhansia ever existed. So farewell, Adhansia XR. You bit the dust. And it's like one of the most of the other ones that are gone are ones that like came out like 50 years ago. I think about Dexedrine, Dextrostat. I think about Ritalin SR, Methylin CT, Methylin CD, Metadate CD, or I don't know if it was Metadate CD, one of the Metadates as well. So like these older products, I think they just, that why is this company making them anymore? They're off patent. No one wants the old branded product that costs 10 times more. The generics, and there's generics of like basically all those products out there anyway. And so if you want to get them, you can. And so it's kind of like, well, Dexedrine for a while, there was like no replacement for it, but then Zenzetti came out, which is a very similar product, but now Zenzetti's generic, so we can get generic Zenzetti. So there's no reason to really make generic Dexedrine. But like you can essentially get generics of all those other ones. But like Adhansia bit the dust before, I mean, way before its patent expired. I mean, they had 19 years left on this patent. That's a long time whenever the drug came out. And then to just, you know, pull the plug on it 3 years later. Wow. This is when we haven't really seen anything like that up to this point where a drug still under patent was pulled, except we might see it for safety reasons, but that wasn't why. Like, it doesn't, I can't find an explanation, but it said it wasn't any kind of safety issue. And why would it be? This is just methylphenidate. The drug is no different than anything else. So Adhansia gone, will it come back? Probably not. So that kind of rounds out our methylphenidate and methylphenidate ER products, but we're not done with methylphenidate. We've got dexmethylphenidate. All right, so I saved the dexes for last. I think we talked about the dex amphetamine products. Kind of, I organized them inside in chronological order, but because Focalin and Focalin XR came out so far apart, not really that far apart, I wanted them together. All right, so I decided to group the dexmethylphenidates together. So, as you know, with their amphetamine products, we have the left enantiomer and the right enantiomer, and the right is dex, right? And then we don't have any isolated left-handed because the right-handed is like the active one, and then the racemic mixture is, you've got a 50-50 mixture of both left and right, right? So those are like the mirror image molecules, right? And the dex is kind of thought to be the more active, but it's not like the left doesn't do anything. And we've got that with amphetamine, and we've got the same situation with methylphenidate. And remember, with the dex products that we have for amphetamine, we have the Dexedrine, now Zenzetti, now generic Zenzetti, dextroamphetamine. We have Dexedrine Spansul, so we still have a Dexedrine product, but it's the long-acting version. And then we have lisdexamphetamine, which is Vyvanse, which is a dex product, but a little bit different because of the way it gets released into the system, but it's only releasing the dex product. So those are our dexes on the amphetamine side, and here are our dex products on the methylphenidate side. So we've got dexmethylphenidate, Focalin, 2001. One thing that you have to think about when you have one of these kind of, single enantiomers, not the racemic mixtures. So this is a D enantiomer, dextro, right-handed, right? They are half of what would be in the racemic. And so oftentimes half the dose is equivalent. And I think about Lexapro and Celexa, right? You've got, in that case, it's the left-handed that's the active, and citalopram and S-citalopram, right? So S is left. Sometimes it's L, but sometimes it's S because sinister, because left-handed people are evil, right? So we've got here, it's the dex that's more potent. And so what happens is kind of like with Celexa and Lexapro, where you have 20 milligrams of Celexa equivalent to 10 of Lexapro, 40 milligrams of Celexa equivalent to 20 milligrams of Lexapro. It's the same deal. It's like, because it's only half of the mixture, the potency is at half the dose. So this is dose 2.5 to 10 milligrams BID, because remember, this is the IR, immediate release product. You can go up as high, apparently, as 50 off label. That sounds pretty insane to me, since 20 is the max. Dose equivalent of 5 is 10, right, of methylphenidate. The max dose of 10 twice a day, which would be 20, would be equivalent to 40 of methylphenidate. So that's not quite as much as the 60 max. But, this is the immediate release product. We'll talk about the extended release here in a second. It's a tablet. Onset of action, same, 20 to 60 minutes. Time to peak, 1 to 2 hours. Duration, 3 to 4 hours. This is a short-acting product. Can you split it? Yes. Age 6 and up. Immediate release D-enantiomer of methylphenidate. What is that really doing for us? So it's, I don't know, when I look at the Ki values of its interaction with the norepinephrine and dopamine reuptake pumps, it shows like a more balanced um, action on those pumps versus the racemic mixture having 6.5 times more potency for the dopamine reuptake pump. And I would think of that as like kind of counterintuitive to like how this drug actually works, because it's like, wouldn't we want more potency of the dopamine reuptake pump? That's the one that helps us more with concentration. However, Focalin is kind of known to have less adverse effects and a smoother, more effective treatment. And so I think a lot of people don't think about Focalin or dexmethylphenidate, but like if you're having problems with tolerance of either amphetamine products, say Adderall or Concerta, a methylphenidate product, think about Focalin, right? Like if someone's having issues with, things lasting, coming off too fast, being too bumpy, the kind of irritable and not having that smooth action of like the drug being continuously in their system, and maybe they're getting adverse effects, I would think about methylphenidate if you're having those issues. So it's known to have less adverse effects and a smoother curve and maybe be a little bit more effective. That left-handed enantiomer is thought to not be terribly effective, and so kind of tossing it out the window, you could toss out some of those bad effects. And it's generic. All right, yeah, 2001, pretty old product. And then that brings us to the next product, dexmethylphenidate ER, brand name Focalin XR. This came out 4 years later, 2005. Um, so this is kind of interesting. It's dosed 5 to 30 milligrams in the morning, 50 milligrams off label for children, and 10 to 40 milligrams in the morning for adults. And it has that same 5 milligrams equivalent to 10 of methylphenidate. But when you think about it, the max dose for adults is equivalent to 80 milligrams. So whereas the IR product, we kind of max out at 40, um, perhaps we can, an equivalency of 40. That's why I think we can go off label on the IR. It's like a 40 milligram total dose. I mean, we can go higher than that, right? Because look, and then we get to the XR product, they go like double that, but the IR is typically not used for adults so much, and the XR would be. All right, so it's a capsule, 20 to 60 minutes, onset of action, time to peak 1 to 2 hours, duration 8 to 12, pretty good there. Um, can you split it? Okay, this is another good point. It can be sprinkled. Do not crush or chew it, right? Because it's a capsule with beads, so you want to just like you want to swallow those little tiny beads if you can't swallow the pill, and if you wanted to split it and like kind of do half and half inside the little capsule. Um, I know what you may think. Oh, they'll say don't split it but you can sprinkle it, right? They'll say, oh, you can dump the contents out, but don't split it. But like you really can, right? Like when you have the beads inside the capsule, it can be a little challenging. You're going to have to like, this is how I would do it. I've done this before. You kind of screw those little two pieces of the capsule apart, and then you kind of dump the little beads in between the two and kind of look to see that you have the same level of each, right? And then go ahead and toss the half from, that's in one side of that capsule, into your mouth or into your pudding or whatever, and then go ahead and seal that back up. And then you've got a pill with a half in it. Now you're going to want to remember that this is the one that you're going to want to take tomorrow. And so like I would keep this capsule in a separate location, maybe in a separate pill bottle or whatever. That way the next day you just dump all the contents from that out. So, they don't recommend that because it can be a little bit challenging, but you can do that. you don't necessarily need to split it because they have different doses. But sometimes doing something like that, sometimes it saves money. Sometimes, they'll have like 10, 20 milligram capsules at the same price. And so if you give them 20s and tell them to take half, ooh, sorry, drug company, you don't want us to do that. And then they basically can get it for half the price and then just use half of the bigger one. But because they've said, you can't split this, then they, end up charging the same price. Sometimes they do that where they just charge the same price for different doses, and they'll charge the same price for like the lower doses, and then they'll like double the price and have a higher price for all the higher doses, but like several doses will have the same price. It's, I don't know, it's strange to me. This is used for 6 and up. It contains 50% immediate release beads and 50% delayed release beads, and it's generic. So this product actually is one of this may be I think this may be the first one of our methylphenidate products that has all of these characteristics in common. Generic, meaning cheap. You can sprinkle it or split it, and it's long acting, right? So let's go. Let me just go back and look and see if we have any other products that are long acting, generic, and can be sprinkled. Let's go back and take a look here. So Adhansia, you're gone. Jornay, you're a different type of med. Cotempla is going to be generic in 2026. So that one is going to meet that category soon, but it's not in it now, and it hasn't been for the last 20 years that we've had Focalin XR. Aptensio is generic. So there's one option that we have that is long acting splittable generic. Quilichu, not generic till 2033. Quilivant 2031. Um, let's see. And then, of course, the patch is generic, so this is an option. But as I said, you can't really use this for older kids. This is only 6 to 12, so you have that limitation with Daytrana. But it essentially, you can titrate that one, and it's generic. Concerta is not splittable. Ritalin LA is generic, and you can sprinkle it. I just its curve is it's not terrible, to be honest with you. So Ritalin LA, lot, I don't know, just some people don't like it that much, but that one is an option. Your Ritalin LA, and then SR, we can't find that one anymore, and the rest of these are not long acting. So there are a few. We've got Ritalin LA, we've got Daytrana kind of for younger kids, and then we've got Aptensio. I'm kind of surprised that one is already generic because it only came out in 2015, and it can last up to 16 hours. And so, I mean, that might be a problem for younger kids. We don't necessarily want something that's that long acting. So that actually could be an issue there, um, having it being too long acting. And then Cotempla we've almost got. And then we've got Focalin XR. So Focalin XR is a good option because of the, splittable, sprinkleable, generic, um, and then the fact that it's got that pure dex, it's got less side effects. Focalin XR is actually a really good option. If I treated kids, I would probably use this like fairly often, but for adults here's another thing. Adults don't have a lot of tolerance issues in my experience with these medications. They just they don't. Like, I'm a psychiatrist, so I prescribe all types of psychiatric medications, and the medication I have people complain about the least about side effects are the ADHD medications. I know we talk a lot about those, and we're going to have several episodes here coming up. I think the next several are going to be about all the adverse effects, because now we've kind of talked about all the meds, and then now we'll talk about all the adverse effects. Most of those adverse effects, honestly, only affect kids. I mean, they can affect adults. Um, Probably increased heart rate or something like that would be one of your more common ones. That's not something that necessarily bothers them, but it's something that you don't want to happen, and you're going to want to mediate. But adults tend to tolerate these pretty fine. Um, the antidepressants are real hard to tolerate. The antipsychotics, the mood stabilizers, most of the medications I prescribe are not hard to tolerate. The ones that they're tolerated well are the controlled substances. So we're talking about like your Ambiens, your benzos, your stimulants, right? These are, surprise, they're controlled substances. They can be, potentially abused, or tolerance, withdrawal issues, things like that. These people tend to tolerate these fairly well. Um, I'd say probably one of the more common side effects is like maybe disturbed sleep. But honestly, the thing that people complain about enough is that it's not effective enough. Like they need more effect. It doesn't last long enough. It's not strong enough. Things like that. Those are their complaints. That they need like maybe a higher dose, or they need something that lasts longer, and maybe it disturbs their sleep. But honestly, for most of the side effects, they're not really having these issues. So like I really don't have to turn to Focalin XR for adults often at all. And I don't treat kids. If I did, and I have, I've trained on children and things, and they do tend to have more issues with these medications. And so going to something like a Focalin XR, or Focalin in general, a dexmethylphenidate product, might be something more to think about for those of you treating children. And something to keep in your mind, back of your mind, for adults too. It's not like adults don't tolerate these medications. That does happen. I just almost never see it. And I think comparatively to like I said, my adults that I treat with other psychiatric medications, I'm constantly mediating adverse effects. And with ADHD, what I love about these meds are they work fast. They're the most effective meds we prescribe. They work quicker than any other med that we prescribe, and they're more well tolerated than any meds we prescribe. And so like I enjoy prescribing them because they're effective, and I can get people better fast. And it's like, oh, we got you where you need to be, and now we can, you know, d- just give you refills, and I don't have to see you every month anymore, and I've got room in my schedule to fit more patients in. So it's very satisfying to me to prescribe stimulants for those reasons. So that's Focalin XR. Um, and then next we have one more methylphenidate product. This one has a really long name. It's serdexmethylphenidate, dexmethylphenidate, and, and its brand name is Azstarys. That's spelled Azstarys, and they have a little star in their emblem, and they've colored the word star in the middle a different color on their emblem. Azstarys. This came out pretty recently, 2021, and you may be wondering, serdexmethylphenidate, dexmethylphenidate. Why are we saying dexmethylphenidate twice? Well, that's because there's two drugs in here. There's both serdexmethylphenidate and dexmethylphenidate. So the next thing you're thinking is, what is serdexmethylphenidate? Well, remember lisdexamfetamine, Vyvanse? It had that lysine group on it that's cleaved with the enzymatic activity of red blood cells. This is similar. This one has a serine group on it. So lysine and serine are those amino acids or something like that, right? So these are just like kind of on there, making them inactive until they are activated. Now, in the case of lisdexamfetamine, we didn't have a short acting product with it, but this one contains a short acting product with it as well. We're going to talk about that. And in the case of lisdexamfetamine, it was the enzymatic activity of red blood cells, which I thought was super cool, that actually cleaves that lysine group and activating the amphetamine. All right. With this one, it's actually activated in a different way. And we're going to talk about that in a second. So the serdexmethylphenidate is a prodrug that is inactive until it's converted to dexmethylphenidate in the lower gut. And I searched high and low. They do not want to tell us how this works. Lisdexamfetamine, we know it's the enzymatic activity of the red blood cell. In the case of serdexmethylphenidate, we know that it's activated in the lower gut, but we do not know how. But somehow in there, serine is cleaved off and we have dexmethylphenidate. All right. But we also had the dexmethylphenidate product that was did not need to have a serine cleaved in the system to begin with. And so you kind of had this effect where you get this immediate acting effect from that dexamphetamine product or dexmethylphenidate product. And then as that serine is being cleaved off, you're getting more dexmethylphenidate absorbed over time after that as well. So whereas your Vyvanse lisdexamphetamine can take a little bit longer to kick in, this one kicks in faster because it's included that in there. So I just want to go back and remind ourselves. Let's look at Vyvanse and see how long it takes to act. So yeah, they put 60 minutes. Most of these say 20 to 60 minutes, but with Vyvanse, it's like a clear at least 60 minutes. So it does take a bit longer to work because it takes longer before that gets activated. But with this one, they've solved that problem. And this is actually one of the things they highlight. Its onset of action is 30 minutes. So as opposed to 20 to 60. So supposedly this is like the fastest acting product that there is. So that's one selling point. It's also the dosing's a little weird sounding. So you've got to have the dose of the two different drugs. And so you start off with 26.1 hyphen 5.2. So it's 26.1 of the serdexmethylphenidate and 5.2 milligrams of the dexmethylphenidate. And then the range would be that's the lowest dose, and the highest dose would be 52.3, 10.4, right? And then the equivalency is that 15.65 milligrams is equivalent to 20 milligrams of methylphenidate. So if you've got the 26.1, 5.2 product, what is that? That's like 31.3. That's actually equivalent to 20 milligrams of dexmethylphenidate, which is what this product is, which is equivalent to 40 of methylphenidate. So that's the lowest dose. That's kind of a higher starting dose too. So you're starting at 40. You don't really have that option of starting at 20. So yeah, you're forced to kind of start at like a higher dose than you might otherwise want to. I usually start at equivalent of 40, but sometimes I will start at 20. You don't really have that option here. But you can split it. So you could say, just take half of that. But it's a capsule. So you have to deal with that, go back and forth thing. That's a little unfortunate. And then that highest dose is actually equivalent to 80 milligrams of methylphenidate. So once again, kind of like Adhansia, which is gone. Adhansia was the first product we kind of came across that went up to an 80 milligram FDA approved dose. And then we have Focalin XR, which is kind of equivalent. Its highest dose is kind of equivalent to 80. So, okay, we can't use Adhansia. We have Focalin XR. And then we also have Azstarys. It also has kind of an equivalency of 80 milligrams of methylphenidate. So these, you can go a little bit higher, a little bit easier. It has that faster onset of action, time to peak 2 hours. And here's another selling point, duration is 13 hours. So it lasts a little bit longer than a lot of our other products, which kind of tap out at 12, right? So let's see. Let's go back and look at that as well. Do we remember any products that last longer? That Adhansia we know does, but it's gone. Ojorne, that one's just because it's delayed. And then we do have Aptensio has that longer action. I thought there was one in there. So that Aptensio is probably our longest option. And then this is now our next longest option. So that's another selling point. So you can split it, ages 6 and up. 30% of the beads are the immediate release, and 70% are the beads that are the slowly metabolized in the lower gut. It's and then these are the selling points that I went on. I like to go on the person, the company that's marketing the drug, and see, what do you think the selling points are? Well, they seem to highlight that it's the first fast and long acting ADHD medication. And I had to think about that. What does that mean? The first fast and long acting? I mean, we have other, think about Adderall. It acts quickly. It's got an IR in it, and then it's long acting because it's got the XR in there as well. Like, and so I think what they're trying to say is, like, when I look at their curve, they don't really have a second bump for that XR. It just kind of goes up and then lasts. So I think that's probably what they're getting at. I mean, when you think about something like Dianavel, it also kind of works, fast and long. But I think they're like kind of bragging about this like onset of action of 30 minutes. I mean, I don't know why their product would act any faster than anything else. I mean, it's just the dexmethylphenidate that's doing that, and like every one of these products has dexmethylphenidate in it. And so, like, even the racemic mixtures have dexmethylphenidate in it. So there's really no reason why it should be a faster acting product. So essentially, they claim that it's the first fast and long acting ADHD medication. And I don't know, I kind of take issue with that because I think there are other medications that are fast and long acting. I think if you're comparing it to Vyvanse, it's faster than Vyvanse, yes. But there are medications like, say, a Dianavel, something like that, it's going to act just as quickly, and it's still going to have that kind of long acting effect. That they're basically talking about, the long acting effect is like not a second peak. And well, I think the other thing is that they're claiming that this like acting 13 hours is a long acting, whereas like all the other meds are like 12. Um, and so, but here's the other thing that they claim. They say first fast and long acting ADHD medication. So like they're not even comparing it to methylphenidate. I think if you compared it to methylphenidates, maybe you could make an argument that this like 13 hours is a longer acting and it's faster. But when you compare it to all ADHD medications, this is just a sales point. So like I feel like, don't be fooled by this nonsense. And saying it's fast, I don't believe that it's acts any. I don't see under what mechanism this drug would work any faster than most of the other medications. Of course, it'll work faster than a patch, or it'll work faster than Vyvanse, things like that. But like any kind of capsule or tablet, there's no reason for this to work, or even a liquid. There's no reason for this to work any faster. So like that claim is kind of silly. And many medications are also long acting, and in fact, many are as long acting, if not more long acting than this one. So I think it's cool that it's fast and long acting, but like for them to say the first one, that seems kind of silly. They also claim a smoother, more gradual taper, and I think when you look at the curve, that is something that you do see. So I think that because of the way it's, you know, metabolized in the lower gut, you are getting a smoother, more gradual taper. And that's going to be similar to like patch products, or like Vyvanse, or even like some of the liquids with the, like the Quillavant or the Dianavel, things like that. So it's not unique. And I mean, here's the downside for this one. It's not generic until 2037. So now that Adhansia doesn't exist anymore, this one is like now the one that's going to be branded the longest, which means it's going to be more expensive, harder to get approved, etc. But again, it's got advantages. And because this is such a unique product, I'm going to talk about it a little bit more. Let's hear a little bit more about that dexmethylphenidate stuff. So this is a novel compound that's inactive until metabolized by unknown enzymes in the gut into dexmethylphenidate. Um, and kind of like we had with lisdexamphetamine, Vyvanse, it's got a very low activity if it's snorted or injected. And so like if that's a concern, where the patient's going to do it, or someone in the patient's household is going to steal it and do that, because that's another concern. Patients with ADHD don't tend to abuse their products. people that don't have ADHD that convince their doctors to give them a med for ADHD may abuse their products, and people in the household of someone who has ADHD or has access to the household, whether that's family, friends, or whatever, they may steal the product and do these things. Now, another thing, sometimes people sell their products. Some people, they have ADHD and they get these products, and and rather than take the medication that they need, they sell it to other people, and then those people abuse it. So there are ways to, I think the abuse issue is overblown. I think the abuse issue with like somebody who actually needs the product and like has ADHD and takes it for that and like benefits from it, those people are like not very likely to abuse it. And I'm gonna have a whole episode on abuse, maybe two, to kind of really ferret out this issue. But one advantage of this product, as we had with lisdexamphetamine, is that because it needs to be activated in the gut, whereas with lisdexamphetamine we had to have it activated by red blood cells, which are in the blood, which if you snort or shoot it, that's going to happen, but it doesn't increase the speed at which it will get activated. Therefore, there was less of that. Now with this one, you are going to, we do have the dexmethylphenidate in there, and so if you snort or shoot that portion of it, which is 5.2 milligrams versus the 26.1 milligrams of the Serdex, it's 5 times lower. So if you snorted that, you're getting a very tiny amount of Dex in that initial that you're going to be able to get high off of. But of course, if you did like a whole bottle, you could get that effect. Unlike with lisdexamphetamine, where you virtually are not going to get any kind of high. This one, because it contains that dexmethylphenidate, you could. But the serdexmethylphenidate part of Azstarys, because that has to be activated in the gut, if you snorted or injected that part of it, it wouldn't work at all, right? Whereas with 5-ants, I kind of think, well, it would still work. It just wouldn't work faster or more intensely, like if you did that with pretty much any other formulation of amphetamines or methylphenidate. They would, if you crushed, snorted, shot them up in your veins or whatever, you would get high quickly and intensely, and it wouldn't last as long. But with 5-ants, because of the way it's activated, it would still work, but probably about the same as if you had swallowed it. On the other hand, with serdexmethylphenidate, it wouldn't work pretty much at all because it wouldn't be activated at all because it wouldn't get in your gut. But of course, the smaller, the 5 times less amount of dexmethylphenidate that's in there, that part would get intense. And if you took a lot of it, then you might get some sort of effect. So like, I guess this would be a little bit less, maybe I would say 5-ants, lisdexamphetamine would be the least likely that you'd be able to get high off of doing something like that. And this would be slightly more, but like way less than everything else. All right. And because of that, it's actually the only stimulant which is a Schedule 4 controlled substance. Honestly, I don't know why it gets to be a Schedule 4 and lisdexamphetamine doesn't. I'd like to hear the FDA's explanation, or is it the DEA that does this? DEA does scheduling. Yeah, FDA does approvals and safety and things, but DEA does drug scheduling. I don't know why lisdexamphetamine can't be Schedule 4. I feel like they should retroactively go back and be like, you know what? Since we gave this one Schedule 4, we can give that one Schedule 4, because the disadvantage here is that I think because serdexmethylphenidate is a Schedule 4 controlled substance, but Adstarys, because it has the dexmethylphenidate in it, it's overall a Schedule 2 because dexmethylphenidate is Schedule 2. So it gets defaulted to the highest level of scheduling. And so I kind of feel like the company making Adstarys is like, hey, we could always release serdexmethylphenidate in the future, and it would be really easy to do the studies on it, and we could get it approved, and then we'd have the only Schedule 4 controlled substance that was prescribable, that's a stimulant for ADHD, and like then we could extend our patent even further. It's like, I feel like if the DEA said, you know what, lisdexamphetamine, you're a Schedule 4, then Adstarys would quickly put this out. But I feel like they're holding it back because they're thinking, oh, we're going to be able to benefit from this financially, and there's no point in us doing that now because it would just compete with this product. And because this product's not going to be generic until 2037, they may just hold on to dexmethylphenidate, serdexmethylphenidate for a long freaking time, because it. I'm guessing, and I'm not, I'm not 100%, but I'm guessing that they could like do that separately. Or maybe what they'll do is maybe they can't. Maybe it's by itself. It's probably going to be able to be generic around the same time, because they did get it obviously scheduled separately. I don't know if it's approved separately. Potentially they're going to wait till there's sales of this one aren't doing as well and then release that. Like, I don't know. I have a feeling they're going to release it separately. The disadvantage is, compared to other stimulants, if you just do the serdexmethylphenidate by itself, it takes longer before it works. That's why they added the dexmethylphenidate in there. I don't know how much longer. I mean, when you look at the curve, maybe, I mean, it's hard to tell. It's just hard to tell. It's probably, I don't know, at least an hour, maybe two, maybe longer. It's like I said, it is hard to tell when you look at the curve. The curve's pretty smooth. It peaks up around 30 minutes, and then it drops down until about 4 hours, and then it then slowly goes down from that point. So I don't know if that's around when that the Cerdex is getting converted or what. It's hard to tell. I don't see a curve for just the Cerdex by itself to know how long it takes for that to act, because we don't have that as a separate drug. But it does last longer, and it does take longer before it starts to work, right? So they are also, I've heard, doing research on the Cerdex by itself for other indications. I don't know what, like maybe depression or something like that, but I haven't seen any results from any of that yet, whether positive nor negative. So let's talk a little bit more about how it compares to dexmethylphenidate by itself, as far as kind of how it acts. All right. So when you look at the curves superimposed on each other of like the equivalent doses of dexmethylphenidate compared to the serdexmethylphenidate, dexmethylphenidate Azstarys product, what you'll notice is that their concentration of dexmethylphenidate is much higher than Cerdex until 16 hours, where they cross, and then Cerdex maintains still some level, whereas the dexmethylphenidate is like quickly out after that time. And so I think that's what's contributing to this product lasting longer, but it's not peaking as high. And so that might be the reason. Remember when I said earlier that like the lowest dose is equivalent to 40 of methylphenidate, where we typically will have a 20 available? And perhaps that's because you need the 40 to get a peak high enough to be equivalent to like a 20. Even though it's the same amount of drug, it's spread out over a longer period of time. And so like the fact that this maxes out at that 80 kind of equivalent methylphenidate dose, of course it's 52.3, 10.4 for this product, but kind of the equivalent of like an 80, that may be because you need a higher dose with this one in order to have the same effect, because it does peak lower. And so is this really a product that's approved up to 80, like I was saying before? Maybe not. Now that we don't have Adhansia, perhaps Focalin and XR is the only close one we have. So that's another thing to keep in mind. You may need to dose this higher than the equivalents would suggest, because those peaks are lower. All right. And then you may get more effect out of it, but that may mean that it has more effect on sleep. So that's another thing to consider. And remember, if we have effects on sleep with amphetamines, we can take things like vitamin C to get it quickly out of our system. We don't have that option with methylphenidates. And so less ability to counteract that insomnia by metabolizing the drug out. All right. That finishes off serdexmethylphenidate. And I wanted to, because this is a quick topic, talk about Modafinil Provigil, which came out in 1998, not FDA approved for ADHD, but is and can be used. So let's talk about it. You may guess that its mechanism of action is pretty similar. It's actually, when I look it up, it says, oh, like unknown, but then like it has like some suggested ways that it works, but like I don't know how it's unknown. We can check like how something binds onto receptors. So they're basically saying it's a dopamine receptor, sorry, inhibitor of that dopamine reuptake pump. So kind of like you have an SRI, an NRI, norepinephrine reuptake inhibitor, serotonin. This is a dopamine reuptake inhibitor, right? It doesn't have any norepinephrine, whereas like the stimulants we've talked to about to this point have had that norepinephrine effect, and modafinil doesn't really affect norepinephrine at all. It's just dopamine. And so you could think, wow, that could work for ADHD, right? And it actually, like, it's mainly used to keep people awake, and we'll talk about what it's approved for here in a second. But some other mechanisms of action that it is thought to have, in addition to being a dopamine reuptake inhibitor, is that it activates the release of orexin. And remember, we have these orexin receptor antagonists now, drugs like suvorexant, limborexant, darivorexant. So this is having the opposite, and those help put you to sleep, right? And they're great. I take one, and it's the best sleep med I've ever taken, limborexant. I can't wait to talk about it in more detail when we talk about sleep. It's my favorite sleep med that I've ever experienced. So essentially, modafinil has the opposite effect. It activates the release of orexin. So it's not like a orexin receptor agonist. It actually says that it activates the release of orexin. So that's like a wakeness promoting neurotransmitter. And then it also activates the release of histamine. So we think of like histamine blockers as things that make us sleepy. And so if you're activating the release of histamine, that's going to be wake promoting. And that's primarily what this drug is. And so it's primarily wake promoting through orexin and histamine, theoretically, but it's got this dopamine reuptake inhibition, which may benefit us for ADHD as well, right? And so it actually does promote alertness, wakefulness more than concentration, but it does help with concentration. I've had patients take this and say that it helps with their concentration. They've got it from someone else, or that they said they preferred this over the other stimulants, because it doesn't affect norepinephrine. It's going to have some different effects, so it might be better tolerated. Some people might prefer it. So the studies that have been done demonstrated effect at 400 milligrams. It's kind of a high dose, to be honest with you. I typically would dose this 1 to 200. Its max dose is 400. And they actually did try to get approval for this medication for ADHD. And so the trials that they did showed that it worked. However, and this was only on kids, a few of the participants got a rash, 13 out of 1,585, and 1 out of the 1,585 got Stevens-Johnson syndrome. And so they just nixed it. The FDA Pediatric Advisory Committee declined its use because of this one case of Stevens-Johnson syndrome, which, when you have one case, can you know that that was the modafinil that caused it? And as far as I'm aware, there hasn't been any cases since. I don't know how many people use it for that because of this, but that kind of like tanked it for us. And then there's no such warning on adults because there have been no cases I have 4,264 individuals that have been looked at. No one got Stevens-Johnson syndrome in the adult population. Hey, why not get this approved for adults for ADHD? I don't know if the Pediatrics Advisory Committee is like, no, why not try to get it for adults? It's unfortunate that there was that one case, and that this is the kind of ridiculousness that can happen. You get one case of something, and it's like Seroquel and how effective it is for anxiety and depression, but because of the metabolic effects, they won't even approve it for anxiety and depression. And I feel like, in some individuals, it certainly could help, right? And we can use it off label, but it's used less because of that. But at the same time, like, we do have a lot of other options, and I also like to avoid the metabolic effects. But I'd also kind of like to have the choice to have it approved and just like saying, no, I don't want to do it because of that. But yeah, I would be a little bit nervous to prescribe modafinil to children because of this warning, because, God forbid something did happen, you'd have some nasty liability. And then these 13 that had the rash, these may have been kids that were going in the direction of SJS. We know that with drugs like lamotrigine, 10% of people get a rash and almost no one gets Stevens-Johnson's. And also With lamotrigine, we have apparently no problem having that approved for seizures for kids, but like modafinil for ADHD, God forbid, this one case prevents us when we've had a number of cases with lamotrigine not stop us. Um, there is a nice interesting story to that too. Like it used to be a lot more cases and they reformulated it and made a lower dose, and now it's a lot more rare, but it still can happen. Unlike this one, we don't even have proof that it does. Just one case. All right. So with that being said, what is it actually approved for? Narcolepsy related or obstructive sleep apnea related excessive daytime sleepiness. So the way we treat narcolepsy is we give people sedatives at night, particularly sodium oxybate, or we've got, which is Xyrem, and then we've got Xywav now, which is like mixed salts oxybate. And then you give them that to help them sleep, and then you give them typically methylphenidate or amphetamine to stay awake during the day, but modafinil also an option. And then folks that have sleep apnea often have daytime sleepiness, and so it's approved for those folks as well. It's approved for shift work disorder related excessive daytime sleepiness. So if someone changes shifts frequently, um, you might give them meds to help them sleep and wake up, to help them adjust to the new schedule before they have to go back. I don't know. I In the military, sometimes they do things in a really stupid way, and like I just want to yell at these commanders and be like, "There's no reason for this." Like they will change someone's shift weekly, and it's like you're on days, you're on mids, you're on nights. It's like, can they not be on one shift for a month at least before we switch them? It's like you're constantly changing their circadian rhythm, like, and it's like, and when I say weekly, it'll be like they're on for 4 days, off for 3 days, and then like the very next shift they have, right? They have a 4 day shift where they're on a particular time, and then they have their days off, and then the next time they come on shift, they're on a new one. It's like, oh, well, you should have adjusted during the 3 days you had off, and it's like, there's no reason for this. Make the shifts longer. I've had so many patients that I've had to deal with their sleep issues because they're on some rapidly changing shifts when there's like no reason they can't be on these shifts for longer periods of time. I don't know. I guess there's this idea that, oh, people don't want to be on nights for a month, and it's like, it's really not that big a deal. I actually kind of like nights. And sometimes you have people that are like, I like nights, just keep me on nights all the time. I'm a vampire. I had a nurse say she's a vampire, and she was always on nights. And so like that meant that we only had to have one other person rotating on nights, because you only need two, right? If the nurses, they're sharing shifts, so like one is taking the days that she's off, instead of having two people have to switch over to nights, you only had to have one. So sometimes people want to volunteer for a particular shift. Maybe they want to be on evening shift, or night shift. That just works better for them for whatever reason. um, in the military, I don't know how it is in the civilian world, but in the military, there's not a lot of brains put into things. They just kind of like do, like the people in charge just kind of like do what's best for them, what makes their life easier, and they don't really take into consideration the comfort of the people that work under them. And it's like, well, I need you here for this. And it's like they'll do this other crap where it's like someone's on night shift, but we have an all hands meeting, which means everyone has to come to this meeting, whether you're on night shift or not. And they'll have it at like noon. And so it's like, so someone's on night shift, they finish at 7 in the morning, and then they have to stick around for 5 hours rather than going to sleep just to go to some stupid meeting they really don't actually learn anything or get anything out of. And it's like, oh, rather than have this all hands meeting in the morning at the end of their shift, you're going to have it in the middle of the day. That's just insane to me. I don't like why you would do this to somebody, but this is what they do. They don't take this into consideration. And whenever the points are brought up, they get upset, which makes me upset, because then, I'm dealing with these people, and I have a lot of empathy. I have a lot of sleep issues myself. And like, I really empathize with people that are kind of unnecessarily put onto a crappy sleep schedule. So I'll get off my soapbox for a second. We'll talk a lot about sleep. I'm probably going to do sleep after ADHD, and we'll talk about all the sleep, everything you ever wanted to know about sleep. We'll go through every single diagnosis in the DSM and all the treatments for all those disorders. It's going to be rad. All right. So you can FDA approved shift work disorder for modafinil. All right, it is a Schedule 4 controlled substance, which is we'll talk about like the different scheduling. Schedule 1 can't prescribe it. Schedule 2 can't give refills, can't give more than 90-day supply. Schedule 3, and I think you can't call in on one of these. Maybe Schedule 3, like you can't call them in. We'll talk about all that stuff when we talk about scheduled drugs in general. But Schedule 4 is not a huge level of control. I think for this one, it's like you can't give them more than 6 months, including refills or something like that. It's something like that. But it's a level of control, and it's like, hey, it's also kind of a warning to the provider of like, hey, this could be, something that was abusable, just so you're aware. Um, and when I think about Schedule 4, I think about the benzos are in Schedule 4. That's a lot of what's in Schedule 4 are benzos and some of the barbiturates, the longer acting ones. Schedule 2, I think about opiates and stimulants are the big ones that I think about being in Schedule 2. So here's another advantage of modafinil. It is a stimulant medication, and it is Schedule 4. I talked about serdexmethylphenidate here a second ago as a potential Schedule 4. This is actually a Schedule 4. It's just not approved for ADHD. But it can be used off-label for cancer-related fatigue, major depressive disorder, multiple sclerosis-related fatigue, Parkinson's disease-related excessive daytime sleepiness, myotonic dystrophy-related excessive daytime sleepiness, idiopathic hypersomnia, TBI-related fatigue, and ADHD. So a lot of fatigue and sleepiness-related conditions to other medical conditions. Idiopathic hypersomnia just means that like you're somebody who needs more sleep than most people, and you sleep like 10 to 12 hours every day, and maybe that's just not functional for you. And like if we need to like you need to be able to work and stuff and fit that into your schedule, taking something like modafinil off label could help. This is just like basically just genetically engineered in your brain. This is just someone who needs a lot more sleep than the rest of us. Idiopathic means kind of like we don't really know the reason, and hypersomnia means like lots of sleep. um, but the rest of those are all kind of fatigue related, or daytime sleepiness related to some medical condition. And then we had depression in there. So like sometimes with depression we have like fatigue and energy issues as a symptom. So adding modafinil might be something you consider. We probably talked about that when we talked about depression series. And then of course ADHD, right? So I like this medication. I haven't really seen many problems with it. um, it does have some. I've taken this medication because I do change time zones a lot, and so like I've used that to help with like jet lag related stuff. I don't use it as much as I used to because of some of the adverse effects that I personally don't like. Um, I get really hot when I take this medication. I have noticed that I focus really well. So like I'll be on the plane because I'll be taking it on the plane to keep me up all night long so that I can like arrive at my destination and then sleep then instead of on the plane, so I can kind of adjust the schedule. And I'll notice like I'm really like I work on my podcast and stuff on the plane, and it's like, oh, I'm really getting a lot done here. And then but then I'll notice that like I get hot, and I'll never forget this one time. I was flying to the States from Japan, and then I changed planes in DC and I went to Ottawa, Canada, and it was minus 22 degrees Celsius, which is like around -5 Fahrenheit in Ottawa when I arrived at like midnight, in the middle of February. And I, on the plane, on this like tiny like commuter plane from DC to Ottawa, like everybody's in like winter coats and like long sleeves and everything, and I'm like in shorts, t-shirt. I'm taking my shoes and socks off. I'm like super hot, and I'm like, it's not cold, like I don't understand why people are so cold. um and then I realized, because I always get hot when I take the modafinil on the plane, and I get hot easily. I get hot on planes, and I hate getting hot on planes. So that's why I stopped taking modafinil. I finally realized that's what it was, and like that was the kicker. When I was on this plane, everyone was like, looked like they were going skiing, and I looked like I was going to the beach. I was like, yeah, this is a problem. I've also noticed that like I get like increased heart rate, which, when you only take it once every month or two, not really a big deal. But for me, I was getting hot with it. So it can cause increased heart rate, increased blood pressure, um, which may be uncomfortable if you're noticing palpitations. Um, Potentially, that could cause a problem if you have some sort of cardiac issues. But yeah, the heat for me. And then the other thing is you're going to have trouble going to sleep. So it's like you use it to stay awake so that you can adjust to the time zone. And then you're going to have to take a sleep medication when you get there because modafinil lasts a bit longer than you're going to want it to. You're going to want to take it as soon as possible, so that it has time to wear off. But at the same time, it's it's like wake promoting effects may wear off, but it's still keeping you awake. And that's a problem I see with a lot of the stimulants, where it's like they you're not noticing that your ADHD symptoms are being treated, but you can't sleep. It's like, well, I'm not getting the benefit of the med, but like you're not sleeping because there's still enough drug in your system that's making it to where you can't fall asleep. And so like that's one of the side effects we're going to talk about. And with modafinil, it's got kind of a longer half-life. And so that can be a real issue. All right. And so, just one more drug to talk about, and very briefly, is Armodafinil. Armodafinil, right? So, it's the right R enantiomer of modafinil. And its brand name is Nuvigil. Came out in 2007. Wow, I did not realize this, but Nuvigil has been generic since 2016. This is almost 10 years now. Um, when I was learning, I was always aware that modafinil was the cheaper generic product, but Nuvigil has been, or Armodafinil has been generic for a long time, 2016, and I think there's a lot of good reasons to give this one, and there's some reasons not to. So um, it's very similar. It's got the same FDA indications. One good point about it is its levels are smoother than modafinil. So just kind of how we've talked about that with like the ADHD medications, it's like the amount of drug in your system is just like more consistent, right? And it can has a slightly longer acting than modafinil. So I just got done talking about how modafinil lasts too long, but like its wake promoting part doesn't, in my personal experience, I didn't find its wake promoting effects to last long enough. Now, I've taken modafinil in a couple different situations. One, when I'm trying to adjust to a new time zone and like stay awake on an overnight flight, and sometimes you're in an uncomfortable sleep on seat on the plane and you can't sleep, but you are sleepy, and you're just the kind of person that can't sleep in an upright position, and you're on a trans-Pacific, transatlantic flight, 10, 15 hours, something like that, you know, and then you want to sleep but you can't sleep. I've found that this medication can be helpful. I start getting restless leg whenever I can't sleep, and so this helps treat that, and I don't get the restless leg, and I'm able to like be alert and not feel like crap, like I can't sleep because I can't lie down. One reason why I like to be in the lie down seats if possible. It's much easier to sleep. I can't sleep upright at all, even like reclined a little bit. I personally just can't sleep like that. And so I will use it in that situation. And I find that like when I'm trying to actually stay up longer than a normal period of time, like because when I'm changing time zones, I'm basically trying to stay awake longer and then fall asleep at my new destination if I'm arriving at night. Sometimes you're arriving in the morning, sometimes you're arriving at night. You kind of have to take that into consideration. But another way I might use it is, say I'm in a new time zone and it's time to get up, or say I arrive in the morning and maybe I did sleep, but not, maybe I didn't sleep that well on the plane. I slept like 3 or 4 hours, but now it's like 7 a.m. in my new time zone. Um, I'm still sleepy, but I did get some sleep. That might be a good time to use this medication. And in those cases, because I have gotten some sleep and I'm basically taking it earlier in like the new day I'm in, um, I feel like it works a little bit better. But when I'm trying to extend the amount that I'm awake to make it to my next time zone, in the case where I'm arriving at night, I find that it maybe does not last long enough. So perhaps an Armodafinil, which I've never taken before, might last a little bit longer when you need it to. So those are some ways that you might want to use it with like the shift work, jet lag type of situation. You kind of look at, am I trying to stay up longer so I can get there at night and go to sleep, or am I trying to, or do I want to use it when I arrive because it's going to be morning where I'm arriving, even though it's night wherever I came from. So that's another thing that I think you can use it for. And then like I know people that like say you have like a baby and you're having to take care of it and you're waking up at night and you're just not feeling, and some nights are worse than others, right? You know, people, and some babies are harder to take care of than others. And then you've got work the next day and you know you're not using it all the time, but you know you're just like unable to get to work, you're unable to function there. I know that I know people that use this medication and it's very helpful for something like that where they just weren't able to get great sleep because of a disturbance such as a baby. There might be a different disturbance that you had. And as long as it's not a daily thing, I think that that could be very useful because like we don't want them getting into a car accident on their way into work. We don't want them, you know, getting fired because they're unable to function at work. And if it's a daily occurrence, we need to come up with a better solution, and they need to have some social changes, you know, to the structure of their life. Um, Maybe some help from somebody to help. You know, maybe they need a, a nurse at night to be in their home, or their mom, or their mother-in-law, or something like that, or a father-in-law, or sister, or something like that. Some help, or maybe maybe they make a decision about maybe both of us are not going to work, kind of thing. But if it's like, hey, you know, it's not that often, but when it happens, it's just absolutely debilitating. And you know, you're giving them 30 pills. It's lasting 6 months. You know, they're not taking it all the time. That could be, you know, once a week kind of thing. That could be another thing that you could use off label. I will, like I said, I'll talk a lot more about sleep later, but like kind of just talking about ADHD. I've given these for ADHD before. I've had patients that took them and I refilled them and they preferred them. So I think this is another thing to consider for ADHD. If you've got someone who maybe isn't a candidate or doesn't do well with the two main stimulants, rather than going to one of the non-stimulants, or if you did try the non-stimulants and those didn't help, here is another option, be it off label. All right. So I want to thank you so much for joining me today. I hope you enjoyed our discussion. We rounded out the stimulants. We finished up on the methylphenidates, and we talked about modafinil and armodafinil. And on our next episode of ADHD, I will be starting to go through the adverse effects from the stimulants, what they are, and what to do about them. So I think you'll really enjoy that as well. Thank you for joining me as always. Please like, follow, whatever, you know, whatever you can do to help me get the word out there. If you really enjoy it, help me spread things, and we'll have more people listening. And I'll see you next time.